Welcome back to the surgical canvas. Today we will be discussing nevus, congenital melanotic nevus, and some pediatric dermatological conditions. Nevus is a benign growth of skin formed by clusters of melanocytes. Classification of nevus is based on depth. For example, in congenital nevus, the melanocytes are present at the junctional level as well as they penetrate deep into dermis and may reach the subcutaneous fat layers. While there is epidermal nevus, dermal nevus, compound nevus, and junctional nevus. Now coming to the congenital melanocytic nevus. This congenital melanocytic nevus is present at birth or within several months. It can be classified based on size. It is called small if the size is less than 1.5 cm, called medium if the size is 1.5 to 20 cm, is large when the size is 20 to 40 cm, and giant when the size is more than 40 cm. This giant congenital melanocytic nevi has accompanying satellite lesions such as these satellite lesions. So this is a medium congenital melanocytic nevi and this is large giant nevi with satellite lesions. There is melanoma risk of 0.7% in case of small and medium sized lesions, but this melanoma risk is 3.1% in case of giant lesion. There is also neurocutaneous melanosis, that is congenital melanocytic nevi associated with neural melanosis. Here the melanoma risk is very high, reaching 17 to 41%. Therefore, in cases where there are multiple medium sized melanocytic nevi, or if there is giant melanocytic nevi, we have to go for MRI brain screening to rule out this neurocutaneous melanosis. There are several clinical signs which can indicate about the melanoma, such as asymmetry, irregular borders, change in color, diameter more than 6 mm, and evolution. If it is suspicious, we have to go for full thickness biopsy. Management is surgical excision. If the size of the lesion is large, we have to go for serial excision, and we can also use tissue expansion technology. We can also go for laser ablation, but there is a risk of melanoma which persists. Now coming to second topic, nevus of Ota. It is oculodermal melanosis. There is pigmentation in distribution of first and second trigeminal nerves. First and second trigeminal nerve regions. It is present in neonatal period or during puberty. It is more common in female and of Asian descent and is often unilateral. There can also be ocular involvement, tympanic membrane involvement, or mucosal involvement. If there is ocular involvement, it may lead to other complications because of increased intraocular pressure. It can lead to glaucoma, uveitis, cataract, ocular melanomas. Treatment of choice is Q-switched lasers, but there are side effects of hypopigmentation. Now coming to nevus of Ito. Here the pigmentation is present along the lateral brachial cutaneous nerve or posterior supraclavicular nerve. It can also occur with nevus of Ota. Now coming to Mongolian spots. These Mongolian spots are congenital blue-gray macules. Most common site is buttocks and the lower lumbosacral region. It disappears on its own in childhood. There is no melanoma risk. This diagnosis may confuse and Doctor may assume it is a bruise due to child abuse or non-accidental trauma. Now coming to Spitz nevus. This is also known as juvenile melanoma. It is a rapidly growing, well circumscribed, dome-shaped pink to red nodule with size less than 1 cm. There is no malignant potential, and this nevus appear before age 10, and most common site is extremities and face and neck. Management is excisional biopsy. There is also another entity known as the atypical Spitz nevi. It often develops after age 10, has irregular borders and color, size is more than 1 cm, and there is risk of malignancy. Now coming to halo nevi. This is due to autoimmune disorder. There is nevi is surrounded by a halo of hypopigmented skin. There is risk of malignancy, therefore monitoring is done, and if some clinical signs of malignancy appears, excision is done. Now coming to dysplastic nevi. This is also known as atypical nevi or Clark nevi. It is an acquired lesion. For clinical diagnosis, at least 3 of the following should be present. The first, there should be no well-defined border. Diameter is more than 5 mm. Variegated color, uneven contour and erythema. There is melanoma risk. If 5 or more dysplastic nevi are present, there is 10 times more risk of melanoma compared to general population. Now, management. Management is excisional biopsy. Important is that when we are doing excisional biopsy, there should be complete excision. It prevents pseudomelanoma. What is pseudomelanoma? Pseudomelanoma is recurrent nevi at biopsy scar which may resemble superficial spreading melanoma and create a diagnostic difficulty. Therefore, we have to go for complete excision when doing biopsy. Prophylactic removal of rest of the lesion is not necessary as it does not eliminate the risk of melanoma. Now coming to the epidermal nevi. Epidermal nevi is present at birth or early childhood. It is of two types. Organoid, where there is prominent adnexal component, or keratinocytic, where there is primarily epidermal differentiation. This keratinocytic epidermal nevi is most common. It is also known as linear verrucous epidermal nevi. There, most of the time it is a solitary lesion with no malignant potential. Clinically, linear patches of plaques or verrucous papule are present, which darkens and thickens at puberty, and after which it is stable. It follows linear patterns on skin known as the lines of Bleschko. Management is full thickness excision of the scar. This full thickness excision leads to scar on the site. If we go for partial thickness excision, there are chances of recurrence. Therefore, sometimes we use the laser ablation. If we are using laser, carbon dioxide laser is best for this. The other part, this organoid epidermal nevi, an example is the nevus sebaceous. There is also an entity called epidermal nevus syndrome. Here there is epidermal nevi with associated anomalies. We will have a separate video for this epidermal nevus syndrome. Now coming to the nevus sebaceous. This is a congenital hematoma of pilosebaceous follicular unit. It is most common on scalp, face and neck. Here there is fleshy cobblestone non-hair bearing skin, which during puberty there is growth phase which can be either oily or crusty. There is high risk of secondary neoplasm. So we have to wait for the child to grow, and following which we go for elective surgical excision. Now coming to some common pediatric skin lesions. Will discuss here cyst of three types. The first will be epidermal inclusion cyst, pilomatrixoma, and the dermoid cyst. Coming to the epidermal inclusion cyst, this is a slow growing subcutaneous lesion with a central pore. Here, keratin debris is accumulated which can be infected and which can rupture, leading to scar. Management is surgical excision along with the central pore of skin, which is also removed. Now coming to the pilomatrixoma. It is also known as the calcifying epithelioma of the Malherbe. It is a benign lesion in head and neck, most common in children and adolescents. Here the origin is hair follicle matrix, which slowly grows and forms subcutaneous nodules and is associated with calcification. Management is complete excision. The third topic is the dermoid cyst. It is a congenital benign lesion occur at the site of the embryonic fusion. Has both ectodermal and mesodermal tissues. The most common site is head and neck, periorbital region, and the nasal region. Midline lesion can have intracranial excision. Therefore, CT scan has to be done, and if lesion has to be removed, craniotomy has to be done. Thank you.